This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. This is our special Journal Club series. Now, if you're a regular here, you know we've been doing this since October of 2016 with specific topics that are part of our content specifications for pediatric hospital medicine and stuff that comes up throughout life. COVID's a great example of that. This is a series we have been doing to really help us understand statistics from a perspective of a healthcare provider or physician for what we need to know. And this episode 6 is one I have been looking forward to. So today we're going to talk about hypothesis testing, type 1 and type 2 errors. And we have now friend of the podcast, Dr. Jenna Carlson, to help us with this. Dr. Carlson is an assistant professor of biostats and human genetics at the director of the MS Biostatistics program in the School of Public Health here at the University of Pittsburgh. She received her PhD in biostats from Pitt in 2017 and completed postdoctoral training in human genetics in 2018 when she joined the faculty at Pitt Public Health. She's an expert in statistical genetics, focusing on genetic epidemiology studies of complex traits. Dr. Carlson also has a passion for statistics education. She teaches several stats courses in Pitt Public Health, as well as our programming workshops through the Health Sciences Library. Dr. Carlson, thank you very much for joining us. So we appreciate it.
Thanks so much for having me. I'm happy to be here.
We have to now do our disclosure statements for conflict of interest because this is still a CME podcast. So, Dr. Carlson, I'll go first and kick it out to you. For Sanofi Company, I was on an advisory board committee for increasing vaccinations in immunocompromised patients.
I don't have anything to disclose.
Okay. Well, for those of you listening at home, this has been a day for me. And Jenna has been extremely kind with her time, so thank you for that. But now that we are here, this is a topic, Jenna, that it's one of the first topics talked about for my biostats course back in medical school, type 1 and type 2 errors and hypothesis testing. And it's one of those, when you hear it, it makes sense, and then you forget it. And then you have to hear it again, and you study it right before the exam. But I have a feeling you're going to be able to help us really understand this.
Well, I'm going to do my best. I feel like this is one of the hardest things to wrap your brain around. So I have a little bit of an analogy that I'm hoping will help understand all of these concepts. So as a good illustration, let's just pretend we're comparing outcomes between two groups in a clinical trial, which is often what we're doing when we're reading the literature. So hypothesis testing works like this. If you can imagine that there are two universes that exist. If you're a fan of like sci-fi or those superhero sequences, that's like the concept of the multiverse. There are several existences. You can think about it like that. And in one of the universes, there's no difference. So the truth is that there's no difference in this outcome between our two groups. This is what in statistics we call the null hypothesis. But in the second universe, one of the groups outperforms the other. This is what we would call the alternative hypothesis. And so the procedure works like this. And how all hypothesis tests work in statistics, whether you're looking at two groups, three groups, all the different outcomes, is that we first pretend that we're in that first universe where there's not a difference in the groups. So the null hypothesis is true. And then we calculate how likely it was to see the data that we saw in our clinical trial that we're looking at, given that that first universe is what's going on. And so if that likelihood is small, then we would say, oh, we must not be in this first universe. We must actually be in the second universe where there actually is a difference instead of the first. And so this is where the concept of p-values come up with. And I know p-values might have, well, for statisticians, they immediately trigger some kind of fight or flight response because they've been under fire in academic publishing, and everybody's got their own opinion about when is appropriate, what's appropriate to talk about a p-value. So I think it's really helpful just understand where that number comes from and what it actually means. So what a p-value is that mathematical calculation of the likelihood of seeing our results if we're in universe one.
Okay. So what you're saying, if I'm understanding this, is in universe one, there is no difference between the two groups we're studying. And therefore, we are operating under that pretense in universe one. So then if we're doing a study and we found a difference, what we're really calculating is what are the odds that what we found was an accident, not really a difference, but just by a chance that happened. And that's what the p-value is telling us. Am I saying that correctly?
Yeah, more or less. So in addition to that, everything you said was right there. Like, we pretend universes one was true. We have to make some kind of modeling assumptions when we're doing that calculation. So we're going to say I'm making a bunch of different assumptions, maybe about what the data, the distribution of the data looks like, or what kind of model would be appropriate to calculate that p-value. So there's an additional little component there, but more or less it's, if this is actually true, how likely was it that just kind of by coincidence I got data that looked like there was a difference, even when in actuality it isn't.
Okay. And that's what the p-value tells us.
Exactly. Yep.
All right. I think I got that.
Good. Yeah.
So you were saying that p-values have been, let's just say, butchered in media, and everyone has their own opinion about them. It's like favorite ice cream flavors at this point. Everyone has their own opinion. But can you talk about that a little bit more?
Sure. So I'll give a very brief history as to why this has come under fire. Probably most of you, the one thing you remember from your stats class is that your p-value, I'm putting air quotations around this, needs to be less than 0.05. Mm-hmm. And we don't remember where 0.05 came from. And so it's kind of this circular chicken and egg problem. Why do colleges and grad schools and training programs teach a p-value of 0.05? We need that to be small. And the answer would be that because that's what the scientific community uses and what journal editors use. They want to see as evidence a small p-value, a small likelihood of getting these results by random chance. Okay. And the question is like, well, why are they still using p as 0.05? And it's because that's what they were taught in school. So it's this problem that just kind of snowballed. And it led to a lot of not great ethical practices of people will do something called p hacking, which is just running analysis after analysis in order to find something that's small and then publish on that.
Oh.
And so that's one of the reasons it's under fire. And so there have been some better guidelines around using p-values, but I think all of them can kind of boil down as to understanding its limitation. It is not the end all be all, and providing other lines of evidence beyond p-values. So some of those guidance would be, here. All right. So some general guidelines for using p-values is to remember what that definition is. P-values themselves are indicating how incompatible the data obtained from a study are from some specified statistical model, assuming universe one. We're in universe one.
Okay.
They themselves, p-values, don't measure probability that anything is true. Or, so they're not, in statistics, we would say you can never prove the null hypothesis. You can never demonstrate just using hypothesis testing that there is no difference between two groups, for example.
Okay, so you can never prove that two groups have a difference. The p-value tells you what the percentage or chance is that the data you came up with happened by chance. So if your p-value is 0.05, to use a number we all know in p-value world, that means if I'm right, 5% of the time I would have gotten my results by happenstance. And 95% of the time, it's real results. Is that correct?
Close. Very close there. And I think in order to talk more about that, we should talk about a little bit more of those properties of hypothesis testing, type 1 and type 2 error, because that's where that 5% actually comes from. Okay. So for hypothesis testing, first you can think about there's a little matrix of, did I get the answer right? So if we were in a pretend world where we knew what the actual truth was, either there is a difference between these groups or there's not. And then our hypothesis testing would arrive at some kind of decision. Either we claimed there was a difference or we did not claim that. So there's two ways you can get it right. You can find a difference when it's actually there, or you can not find a difference when there really isn't a difference. Statisticians have named the two ways to get them wrong, type 1 and type 2 error. And it's super easy to get them confused because they're just numerically ordered. So I'll help clarify what those are. Type 1 error is when we're claiming that there is a difference. We're in that second universe, but actually we're in the first universe. There isn't a difference. So that you can think about type 1 error as a false positive result of the hypothesis.
Sorry?
And type 2 error is we failed to claim we were in the second universe when we actually were. So a false negative, or kind of like the type 1 and type 2 errors can be thought about as, or a type 2 error can be thought about as an absence of evidence. We didn't have evidence of something, but it actually was there. To keep track of which one is type 1 and type 2, I have another analogy from teaching. If you are familiar with the story of the boy who cried wolf,
yes.
Type 1 and it's an illustration of type 1 and type 2 errors on the townspeople's part. So the first part of the story, the boy cries wolf, and all the townspeople come running to help take care of the situation. Okay. That's a type 1 error because they made some kind of decision reaction. Oh, there is a wolf here, but there actually wasn't. Okay. That's type 1 because it happens first in the story. The second thing that happens in the story is that the boy cries wolf, but the townspeople don't come. And that time there actually was a wolf, but they decided that there wasn't. They said he's just faking it. Right? So that's our type 1 and our type 2, the false positive test result and a false negative test result.
I have heard so many analogies over the years help explain this. That is, to be quite frank, the first one that's been helpful. The boy who cried wolf. That was so good.
Everybody remembers the story, right?
Yeah.
So, yeah.
I mean, you read it to you're here as a child. You read it to children. You're in passing. So the first time the townspeople ran because he said wolf, that's a type 1 error because they thought there was a problem or a difference, and there wasn't one. And they got annoyed by him. And the second time, when he's actually telling them there's a difference, there's a problem, they don't come because they think it's not true. Fascinating. That was so great. This whole 13 series episode, that one thing would make it worth it because I have had so much trouble personally remembering those two, how to differentiate. That was great. Thank you.
Love that helps. All of the different, memory tricks that we have to come up with in statistics. I think that one actually sinks in.
Yeah, I got it. Great. Okay. So now I understand. So where do we go from here?
So now that we know what type 1 and type 2 are, we can talk about how these led to that 5% imaginary line in the sand that we've drawn for p-values. So how hypothesis testing works is that we are able, as a statistician or as a researcher, control how often we're going to make a type 1 error. And that's that 5% threshold that says, how comfortable are we in the study with the false positive result? That's going to depend on a lot of different things, but 5% just kind of got adopted historically and reused. And so that's where it comes from, is that people in general feel comfortable with a 5% type 1 error rate. So 5% of the time you are in a universe where there is no difference, but you're going to claim it anyway.
Okay.
And so we want our p-values, that type 1 error rate helps us say if my p-value is smaller than that, then I'm probably not in universe 1. I'm probably in universe 2.
So go ahead.
Oh no, I was just going to say, so a p-value is one piece of evidence that the differences that you see are quote unquote the truth. Small p-value would be less likely to be in universe 1 versus universe 2. So
now I understand type 1 and type 2 errors, and I understand what p-value tells me, the percentage or the chance that the difference I found really doesn't exist. And so we have adopted 5% just seemingly by habit from everyone being trained. So you can theoretically pick whatever you want, but we've adopted 5%. There's no magic to that number. and you were saying about ways to make sure your p-value is, well, you were saying about how p-value isn't the end-all be-all, and there are ways to make sure it's legitimate. Is that correct?
Well, yeah, there's a couple things. A p-value, it isn't an end-all be-all because it's one piece of evidence, but by itself, it isn't super helpful. So it's only getting at this concept of statistical significance. It doesn't measure how large an effect, so how effective the treatment was, or how disparate these two groups are, or the scientific importance of some kind of result. So what I recommend is that a p-value always accompanies some measure of that kind of effect or difference. So looking at the differences in proportions between two groups, report both the proportion and also a p-value. Or another technique is to always include some kind of confidence interval, which I think is a topic for another day, but some measure of effect size that goes along with the p-value. So it's not the only piece of evidence that you're demonstrating from your data.
Okay, so a future episode will have confidence interval, and that along with what it sounds like is taking your data in context. Just because there's a difference doesn't mean it's medically or scientifically helpful. It has to be in context of what we're talking about and the two groups we're looking at. Jenna, this is so helpful. Is there now, or is there more, or is this what we're covering for this episode?
Well, I could tie it into some specific examples from this article, which I think will help solidify the concepts of hypothesis testing a little bit.
That sounds great. Let's do that.
All right. So in the research study that was looking at the randomized clinical trial of the bolus versus continuous NG feeding for infants with bronchiolitis, they had two primary results that are a really great teaching demonstration for hypothesis testing. So the first result that they highlight was that there was no significant difference in length of stay in hospitalization for the infants between the two treatment groups. So between the bolus NG and the continuous NG feeding groups. And so I think the authors do a pretty decent job. What's happening here is that they did a hypothesis test comparing the length of stays between the two groups, and the p-value was large. So they are in a situation where they don't have evidence that they're in a world where there is difference between these two groups. And the way that they've indicated this is they said no significant difference. So this is where all the statisticians are going to lose everybody in the weeds, because we care a lot about the language surrounding these things. The no significant difference means p-value was bigger than 0.05. That's all that means. It doesn't mean that they've proved these things are the same, that there is no actual difference, because it might be that the difference is just really small and you needed a larger study in order to be able to find a difference that is that small. Or it might be that it just so happened that the infants that were enrolled in this trial looked a little bit different than the population, and maybe it makes a big difference in other groups that didn't look like the people who are in this trial. So that was one good example of the hypothesis testing from here. The other one was an example of when they did find a difference, and that was in the proportion of admissions to the intensive care in the continuous NG feed versus the bolus NG feed. So here's an example where they had a small p-value because they made a claim about some difference. And so they're saying that statistically there was a big difference between these two groups.
Okay. Now, going back to your first example, what you're saying when they say that the p-value is greater than 0.05 and there's no significant difference, all that's saying is the p-value is larger than 0.05. And there may be a small difference, or we may have needed more people in the study, so a higher powered study, which we'll talk about in another episode. And here they found a difference between those who go to the ICU and those who do not, p-value less than 0.05, comparing two groups and figuring out where the differences are.
Yes, exactly. Mm-hmm.
This has been extremely helpful. I mean, and using it in the example for the article that we talked about that we're using for these episodes is very, very helpful. So when you read a study and you're looking at the p-value for you, that's that's a minor part, right? That's a minor part of what's going on. You're looking at the whole study, what we're trying to prove, and the p-value is a small part of that, but really how the study is designed and created, how many participants or people or things we're studying are involved, all raises more questions than the p-value itself and answers them.
Yeah, and I think one of the most important take-homes on the diatribe against p-values is that effect sizes matter a lot more. So what I mean by that, if I could make up a situation, not in this clinical trial, but a situation where maybe some treatment, there's a small p-value. So it's a statistically significant result, p-value is less than 0.05, that shortened length of stay in the hospital for infants with bronchiolitis. But let's say that it shortened it by 0.2 days, a couple hours. Is that clinically meaningful? That's something that a clinician would need to decide. And by itself, the p-value isn't going to tell you that. It just says statistically, there was a difference in the length of stay between these two groups. But what the p-value doesn't give you is a measure of how important that result actually is in context. And I think people have created an over-reliance on p-values when they're actually not telling you all of the pieces of information. So kind of on the flip side of that example, you could have a difference in a length of stay that's really big. Maybe there was a difference in these two groups of an entire day or two in length of stay of hospitalization, but the p-value is 0.06. Does that mean like we shouldn't adopt that practice? I don't know, but the p-value is not the stopping point of the discussion. It's one piece that goes along with the results that you see.
That's very helpful. Very, very helpful. Okay. I think I have a better understanding. I just love The Boy That Cried Wolf for type 1 and type 2 errors and the p-value's place in the research world. This was great. Thank you so much.
Thank you so much for having me. I appreciate it.
Is there anything we didn't talk about that you wanted to?
Oh, I think that covers it all.
All right. Well, we'll see you for other episodes. Again, Dr. Jenna Carlson, everyone, for assistant professor here at the University of Pittsburgh and a participant in the statistics education. Thank you so much, Jenna. I appreciate it.
Thanks, Tony. Have a good one.
Thank you for joining us for this Journal Club series at PHM from Pittsburgh. We want to especially thank our expert guests for their time.
Special thanks to the University of Pittsburgh for sponsoring the CME for this podcast, and UPMC Children's Hospital of Pittsburgh for supporting this podcast as well. We want to thank our friends at Dell Children's Medical Center and the University of Texas at Austin for their partnership on this endeavor.
Please email my dad at tony.tarchichi@chp.edu with any questions or comments. And as always, thank you for listening!